My name's Chris Sutton, and I'm going to be performing a regional block video number 8. First things first is I'm going to start with my machine check. So I want to make sure I have my pipeline pressure at least 50, or I want 50 psi pipeline pressure. I also want to check my E-tanks and make sure I have my key, make sure that they're at least halfway full. I want to make sure I have my ambu bag, suction, as well as my rescue meds, my apples, and also extra airway equipment. Airway equipment. As well as check my flow meters and my Link 25, make sure that they're functioning properly, and then do a low pressure check with my flow meters and vaporizers, make sure there's no leakage with my flow meters or my vaporizers, and I also want to make sure my vaporizers are full. I'm going to turn on my machine, make sure that there's AC power, and then I want to calibrate my O2 analyzer and ensure that my CO2 absorbent is not exhausted or desiccated. I'm also going to check make sure I have my standard monitors and that they're set at the appropriate settings, as well as my ventilator settings. I'm also going to check my ventilator valves, and right now I'm going to perform my high pressure check. I'm going to turn on my O2 real quick. I'm going to do my high pressure check. I'm going to make sure that I'm turned from ventilator to manual, and I'm going to turn my APL valve to 70, and I'm going to flush my O2 reservoir. I'm going to flush with my O2 reservoir and inflate my bag to increase my pressure to about 30 centimeters H2O, and ensure that holds for at least 10 seconds while I include my white piece. Okay, so that is my high pressure check. And I'm going to move on to the patient here. All right, so I have John Smith. He is a 32-year-old male with a history of pectus excavatum and exercise-induced asthma, coming to the OR for a NUS procedure, pectus excavatum correction. He has a BMI of 26. His height is 165 centimeters, weighing 60 kilograms. Labs that were taken, CBC, BMP, PT, INR, as well as a chest x-ray. I also asked him, I did a medical assessment, asked him some questions. So John, do you have any history, do you have any issues with, or have you had surgery in the past?
No, this is my first.
Have you had any anesthesia in the past?
No.
Or your family?
Yes, but haven't been any problems.
No issues with anesthesia? Have you or your family had any issues with something called malignant hypothermia?
I don't even know what that is.
Okay, perfect. No issues with malignant hyperthermia. Do you currently take any medications?
Yeah, listed in my chart, I think.
Fluticasone, as well as albuterol, and occasionally NSAIDs for some chest pain, correct?
Yeah.
Okay. Do you have any known allergies?
No.
Okay. And I'm also going to make sure that he has I'm going to do a cardiovascular physical assessment. John, are you able to climb 2 flights of stairs without limitations?
Only if I'm walking. If I'm running, then it triggers my asthma.
Okay. Are you able to walk 2 blocks without any limitations?
No. Yes.
Okay.
Yes, I am able to.
Okay, perfect. Okay, thank you. Okay, great. And so after this, I then performed an airway assessment, and I found that he had a Malapati score class 2, a thyromental distance greater than 7 centimeters, as well as an upper lip bite class 1. He also has an interincisor distance of 3 fingers. He has a neck length or girth that's within normal range. He also has a neck range of motion, that is full range in all directions. I also auscultated his lungs and his heart, and I did find in his heart that I could hear a murmur, identified a murmur, and I'm assuming that's as a result of the compression of the pulmonary outflow tract. That's as a result of the condition for which he's here today. Reviewing his chart, I showed a basic chemistry and metabolic panel that's within normal ranges. HNH and coax were normal. As we already identified, he has no known allergies. I consider him an ASA 2. After reviewing the procedure with the patient, I was able to obtain conformed consent. Okay, so the procedure that we're going to be performing today is we're going to perform an erector spinae block. Some of the risks with this is pneumothorax, local infection, bleeding or hematoma, local anesthetic systemic toxicity, vascular injury, failed or incomplete block. However, some of the benefits, effective pain relief, opioid sparing, reduction of post-operative pain, and improved patient recovery. Indications for this block would be for spinal surgeries, abdominal surgery, breast and thoracic surgery, and orthopedic surgery. If we cannot perform this block, alternatively to this, we could possibly do a thoracic epidural. So I'm going to gather my equipment. In order to perform this block, I have prepared syringes, dosing, stopcock 22 gauge, Stimuplex needle, and a sterile ultrasound probe cover. Prior to this procedure, I'm lightly sedating this patient with 2 milligrams of Versed and 50 micrograms of fentanyl. I have this patient on continuous SpO2 EKG, non-invasive blood pressure, as well as CO2 monitoring. The patient should be alert enough to follow commands and inform me of unexpected pain. So I'm going to perform a timeout, make sure we are performing the correct procedure in the right place with the right person. This is John Smith. He is a 32-year-old male that is coming to have a NUS procedure and will be getting an erector spinae bilaterally between his shoulder blades. The patient will be sitting while the block is placed. The main landmarks for this block is the spinous process and the scapula and the angle of the scapula. So about right here where T4, T5 is. I'm using a ChloraPrep, sterile gloves, and a mask to help ensure a sterile field. Okay, so I'm gonna go ahead and get started. I'm gonna go ahead and get my ultrasound machine ready, make sure I put gel on my ultrasound, and I'm gonna be trying to identify some key landmarks in here. So right here I can identify this is my anterior and this is this is my superior and my inferior. Okay, so what I'm gonna be looking for, I can see right here, I can see my rhomboids, my trapezius muscle, and my erector spinae right there. And that looks like a rib, so I'm gonna come over just a little bit more. Oh, actually might have been, there it is. Okay, that's actually transverse process. So I wanna come in in an in-plane, at an in-plane maneuver angle, or from superior to inferior. So I'm going to come through my trapezius, my rhomboids, erector spinae, and I'm actually going to freeze this right here so I can explain a little bit better. I'm going to bring my TUI needle in, and I'm going to advance until the tip is below the erector spinae muscles. Once in the correct plane, I'm going to inject a small bolus in this region right here, just above the spinous process, which will separate, the transverse process, which will separate the transverse process, confirming proper needle positioning. So for dosing, what I would do is I would do 2 to 30 mils of 0.25 bupivacaine. Since this is a thoracic region, I'm going to be doing 30 mils, and this will get about eight levels of spread, 4 up and 4 down. And I'm gonna be doing 5 mil increments. And so that is how I perform my erector spinae block. Okay, so now I'm gonna just clean up my patient here, just get some of this lube off. All right, so I'm gonna turn this way just so that I can see my central line placement. So now I'm going to be doing central line placement. Positioning, I'm going to have my patient supine, and I'm going to ask my patient to turn to the left, his head all the way to the left, because I'm going to be looking for the right internal jugular vein. Put some lube on again. So key landmarks here, your clavicle, and you have your sternocleidomastoid, you have your sternal head and your clavicular head. So I'm going to ask my patient to kind of lift up his head while I put some resistance on him so I can identify those landmarks. and I can see the two heads right here. So that's where I'm going to place my probe. All right. Oops. Got to freeze my ultrasound. Okay. All right. Perfect. I'm going to go ahead and freeze this. Okay. So I'll show you some of the landmarks here. So looks like that's my cerulocleidomastoid muscle, my carotid artery, and right there, that looks to be that is my internal jugular vein. And that's where I want my approach to be. So just in case I didn't have it the right angles, this is his internal jugular vein. This is the carotid artery as well as the cerulocleidomastoid muscle. So this is actually going to be an out-of-plane approach, and I'll show you from right here. So what I'm actually going to do with the needle is rather than doing an in-plane approach, I'm going to come from the middle. I'm going to go through the middle of the probe, or in the middle, and rather than seeing a long needle come through, you'll actually see a dot, a hypercoic dot. And that would be the needle, and that's what we're trying to place that right in the center of the internal jugular vein. And then I'll place my needle, thread it through, and then I'll be able to I'll have placement. Indications for this: medication administration, fluid management, hemodynamic monitoring, risk, air embolism, blood clots, infection, benefits, providing reliable access to a large vein near the heart for administering medications. And that is my presentation. Thank you.